Hello, everyone. My name is Dr. Sharnita Zeigler Johnson. I'm a faculty member at Thomas Jefferson University, and I am also an epidemiologist and prostate cancer disparities researcher. Today, it is my pleasure to talk to you a little bit about prostate cancer trends and disparities. So prostate cancer is really important when we think about public health. And it's important for a few reasons that come to my mind. One is its very high prevalence in the community. So we often use surveillance to really track the changes in some of the rates related to this disease, to see the incidence mortality rates and how they change over time and who's most impacted by this particular disease. Also, in terms of risk factors, there are no known modifiable risk factors associated with the etiology or development of prostate cancer. So it makes it really difficult to prevent and control this particular cancer. And then with regard to disparities, well, these are some of the greatest disparities that we see in all of cancer. There are global, racial, and socioeconomic status disparities associated with prostate cancer. And we really need to do more work to understand why they exist, why they are so pervasive, and even more importantly, what can we do to promote equity with regard to prostate cancer detection, early detection, treatment, and survivorship quality. Let's talk a little bit about prostate cancer, just give you a little bit of background on prostate cancer epidemiology. So prostate cancer is the most commonly diagnosed cancer among men in the US. And it's also, depending on the year, second or third, in this case, third, leading cause of cancer-related death among men. So what is the prostate gland? Prostate gland is part of the male reproductive system. It's located low in the pelvis between the rectum and the bladder. So you see it here, the bladder right above and the rectum to the right. Its role is to produce and secrete some of the fluid that constitutes semen. And it's normally the size of a walnut in a male who has gone through puberty, but that size may increase with age or other prostate problems. Some of them could be malignancies, cancer related, but many times it's not malignant at all, caused by benign conditions such as inflammation or something called BPH, benign prostatic hyperplasia, which is very common in older men. So the cause of prostate cancer, well, we know it's hormonally driven. Testosterone is definitely involved. Dihydrotestosterone, a very potent form of testosterone in particular, is involved. But it's really unknown what the triggers are that actually cause some men to develop prostate cancer and others not to develop anything that's clinically relevant. In terms of symptoms, it's important to note that when prostate cancer is most treatable in its earliest stages, there are no symptoms at all. But later, as the disease begins to progress, some of the symptoms that you could see include trouble urinating, painful or frequent urination, blood in the urine or semen, painful ejaculation, and lower back or pelvic pain. In terms of prevention, it's hard to tell patients exactly what they can do to prevent this disease because we don't know what the cause is. However, we do know that a healthy lifestyle is just good in general, and early detection is really the key to keeping men from dying from this particular disease. So when we think about early detection, we're really talking about screening. And one way that we can do screening is with a digital rectal exam, also known as the DRE. With the DRE, the doctor does or conducts a manual feel of the prostate with a gloved finger and puts his hand or finger into the rectum just to feel the posterior side of the prostate. And this works best in conjunction with the blood test called the PSA. PSA is the prostate-specific antigen test, and this blood test allows us to determine whether or not there are higher levels of the PSA protein in the blood. Higher levels indicate prostate growth. It doesn't necessarily tell us whether or not someone has cancer, just that the prostate itself is growing. And the cut point that's typically used in clinics is 4 nanograms per mil. So if you're higher than or equal to 4 nanograms per mil, the doctor may want to take a closer look or monitor you, because very often it's not the exact cut point that matters, but perhaps the velocity, the degree or the rate at which the PSA is increasing over time that may be more important. This test is extremely sensitive. It will pick up any growth that occurs in the prostate, but it's very nonspecific, meaning that there are other factors that can influence the PSA level, including obesity, age, other health conditions, and behaviors. And this particular test has also become very controversial in recent years because the PSA can detect so many different tumors in the body. And very often those cancers that are detected, especially very early, will not be clinically relevant. And in other words, they are not tumors that need to be treated. They are not tumors that need or that may result in the death of the patient. Unfortunately, the issue is we don't know which ones will progress. And that makes it very difficult to advise individuals on what they should do in terms of PSA screening. So as I mentioned, what we're trying to do when we screen is to detect prostate cancer at an early stage. So stage is just one way that we can categorize the tumor clinically. So what we're trying to do, if cancer is going to develop, we want to detect it in the earliest stages, stage 1, stage 2, where the cancer is small and has not spread throughout the prostate and certainly hasn't moved outside of the prostate, so that the resection will be easier. Whatever treatment we try to do in terms of surgery or radiation can be better directed and complete. When we move down here to stage 3 and 4, you see that in stage 3, the cancer has actually moved into the lymph nodes, which means it has an opportunity now to move throughout the body. And in stage 4, the cancer is already spread to some other organs. So it becomes extremely difficult to treat. Another way that we categorize prostate cancer is with the Gleason grade. This grading system ranges from 1 to 5. A pathologist will look at the tumor cells underneath a microscope and determine what they look like in terms of clustering and abnormalities. 1 is normal, 5 is completely abnormal, which means that there's a much more aggressive cancer in these higher numbers. So typically the doctor will take, or the pathologist rather, will take 2 sections of the tumor and grade them and add those 2 grades together to get the Gleason score, which ranges then from 2 to 10. So let's talk a little bit about prostate cancer survival. So the lifetime probability of being diagnosed with prostate cancer is about 1 in 10 men. For some groups, it's actually, the probability is even greater. There is a 5-year survival. 5-year survival on cancer is kind of a general benchmark that's used just to talk about how likely a patient is to survive to that 5-year mark. So with regard to local and regional stage, you can see that the 5-year survival is actually pretty good. It's 100%. that individuals will likely not die from prostate cancer. With distant stage, that's where we have a little more concern. It's a 31% 5-year survival. So we were definitely concerned about individuals who are diagnosed with a distant stage, but also are concerned that these local or regional stage individuals that have more aggressive cancers, they could potentially still spread to other areas of the body, especially if the treatment is not complete. So we're concerned about that as well. And you can see when we look at the percent of new cases, 74% of those diagnosed are likely to be diagnosed with a local stage disease, which is amazing. However, just a few years ago, prior to some recommendation changes related to the controversy of the PSA testing, this number was even higher. So there are some changes happening. In this number, in the regional stage and the distant, they were a little bit lower. So they're increasing. So it's something that we have to keep an eye on going forward, because with the controversy, we could now be increasing who's diagnosed with later stage cases. Okay, so let's talk about diagnosis and treatment. So the screening that we were talking about, PSA and DRE, do not actually tell us whether or not a person has cancer. A biopsy is necessary. The PSA test can actually lead to more biopsies among some low-risk men, which is one of the parts, pieces of the controversy as well. But early diagnosis through biopsy can lead to early and optimal treatment in some high-risk groups. So we have to weigh the two of those when we think about PSA testing. And in terms of treatment, surgery, radiation therapy, hormone treatment are all available. Surgery and radiation are typically the first line, and hormone treatment typically is used a little bit later, depending on the stage of the cancer. There's also something called active surveillance. At one time, something similar was called watchful waiting. With active surveillance, the individual already has an increased PSA, already has cancer potentially, and it's just being watched over time. So monitored over time, biopsied over time at specific intervals to make sure that the cancer is not changing or not growing. So with that particular treatment, there's concern about cancer growth and spread that the patient might have. But with those specific intervals of biopsies, hopefully you can go ahead and go to specific treatment as soon as you notice that the cancer is growing or spreading. With the other treatments, of course, there's a concern about incontinence or impotence, and those are very real as well. So there are side effects, essentially, regardless of the treatment. And post-treatment, it's very important that men continue PSA monitoring, just to make sure that the PSA, which should be undetectable, doesn't start increasing again, which would indicate that there's still cancer in the body. In terms of prostate cancer risk factors, there are some, again, not modifiable risk factors. Being of African descent increases your risk for this particular cancer. Older age increases the risk. Having a family history of prostate cancer or other cancers like breast cancer increases your risk. And there are genetic factors such as carrying the BRCA1 and 2, the BRCA1 and 2, which are associated with breast cancer. They could potentially be associated with prostate cancer. And then there's another genetic factor, the Lynch syndrome. Lynch syndrome is a familial hereditary type of colorectal cancer that may also be associated with prostate cancer risk. Other potential risk factors, there are other genetic factors that people are interested in. I know I've studied various factors, including testosterone metabolizing genes and inflammation genes, and of course um, just a slew of other genes. One, carbon metabolism is another one I've been interested in. And the GWAS genes, the genomic wide association study genes. So people are taking a look at a variety of those and using them in different ways. Diet has also been suggested as a potential risk factor, not having a healthy diet. Environmental exposure such as Agent Orange. In fact, those who may have been exposed to Agent Orange in the Vietnam War are suggested to be screened for prostate cancer. And then lifestyle and behaviors, exercise, obesity, those sorts of things have not really been tied too much to the etiology of disease, but could certainly be associated with progression of disease. And there are a number of studies showing those associations. So as I mentioned, prostate cancer is extremely common among African-American or Black men for reasons we don't completely understand. Part of it is likely genetic, but it certainly isn't the entire story. There are other things that are happening. But you can see that the incidence is much higher, about 50% higher for Black men, where the mortality rate is more than twice that of any other group. And again, we really need to understand this a little bit better so that we can hopefully figure out a way to change these particular trends and reduce the disparities that we see related to race. Something else that's interesting, when we think about global prostate cancer, the rates that are highest, we already talked about what happens in North America and among African-American men. And you see the blue lines here are incidence and the red lines are mortality rate. But when you look at the areas with the highest case fatality, we're actually talking about the Caribbean. We're talking about South Africa. We're talking about Middle Africa, West Africa, and East Africa. Okay, these are some of the areas with the highest case fatality. And they also are areas with populations of African descent. So we know that prostate cancer rates for Black men are among the highest in the world. And the story, as I mentioned, might be related to some genetic predisposition, but certainly that doesn't explain all of that disparity that we see. So there are different screening patterns among groups and among populations. Differences in access to quality care, environmental and patient characteristics also affect prostate cancer rates over time and over place. And as we talked about, there have been recent changes in PSA screening recommendations that could also influence the rates that we see and the trends that we see over time. And there are continued improvements all the time in cancer treatment and in survivorship. So you have to consider that too. So it makes it a little difficult sometimes to figure out which way the rates are going to go, the trends are going to go. Because there's a lot of positive things, but then some negative things that are weighing in on this particular disease. So let's talk a little bit more about prostate cancer trends. So here's some SEER data from the US from 1975 to 2017. This is what the incidence rates look like for prostate cancer. Well, something kind of interesting going on. What is that big blip there? Well, that looks like exactly what happened at the time that we started using the PSA test. So the PSA test is so sensitive, it was able to pick up lots of cancers, prostate cancers that had not been detected previously. We also have a nice decline that happened after the early 1990s, and then a more recent decline that happened. And that could be related to the US Preventive Services Task Force screening recommendations, which have changed quite a bit over time because of the controversy about PSA testing. So from 2008, where older men were recommended to not have PSA testing, to 2012, where all men, all healthy men, were recommended to not have PSA screening, to 2018, which isn't shown on here, where the US PSTF kind of changed their mind just a little bit and gave a C grade where there had been a D grade before, to say, okay, let patient and doctor decide, but we still have some concerns about whether or not PSA is being overused. So the incidence, therefore, has declined even more because I think we're not detecting as much prostate cancer as we had been. But that could be reversing just a little bit as we get closer to the change in 2018. Okay, let's talk about mortality rates. And this one shows from 1930 to 2018 what happened. Also very interesting trends. This could potentially be related to the aging population of the US, where we're detecting more prostate cancer and understanding that what people are dying from. So being able to detect it and then know cause of death among older men, and could lead to more prostate cancer mortality. That's perhaps the PSA blip happening in the early 1990s. So again, knowing cause of death a little bit more, increase the likelihood that someone might be diagnosed with prostate cancer and die of prostate cancer. And then you see a fall off. Could this be related to treatment advances that happened around this time? Absolutely. I don't know if anything else was going on as well, but you can see how what's happening with regard to population, with what's happening with regard to demographics, and with regard to clinical advances can certainly impact the rates that we see for disease. So I've done some work studying local prostate cancer trends. And we can do this in two ways. We can look at rates and we can look at proportions. So when we look at rates, we're talking about incidence and mortality rates. So it's the number of new cases divided by the number of individuals in the population at risk at the time of interest. And it's usually expressed per 100,000 individuals. When we're thinking about rates, we're talking about the impact of disease on the general population. And rates can be influenced by changes in the general population. So we have a numerator, which shows the changes in actual number of specific cases, and a denominator then, which is the change in the number of residents in the general population. For proportions, what we're talking about is the number of new cases over the number of all cases at the time of interest. Proportions can be used to help us to describe what's going on with a particular cancer or cancer population. But with proportions, we also have interdependent measures. So one group increases in proportion, another will decrease in proportion because it has to add up to 100%, right? So with proportions, the numerator, we document changes in the actual number of specific cases. And then the denominator, the changes in the total prostate cancer population, which is a subpopulation. So we're talking about the total prostate cancer population for proportions. The denominator for rates is the general population. And both rates and proportions can be influenced by clinical and demographic factors. So we were just talking about this with regard to prostate cancer and the conflicting screening guidelines that have come down. So from the USPSTF and the CDC, who sided with them, providing a grade D. So they're grading screening practices from A to D or A to F, A being the best, and absolutely everyone should do this, right? So we received a grade D for PSA screening of healthy men in 2008, 2012, and then more recently, they changed it to a C. Grade C for men less than age 70. For older men, it's still grade D. But the American Urological Association, American College of Physicians, and the American Cancer Society all disagreed along the way and said this should all be shared decision-making that occurs between the doctor and the patient to decide what's best for that particular patient. So that caused a little bit of uncertainty about who should be screened, and some doctors actually decided not to screen at all, which certainly could influence the rates that we see. There have also been recent clinical advances that could influence the rates that we see with regard to diagnosis, an increase in ultrasound and MRI techniques, and a Gleason grading system update to be more accurate in diagnosis and grading. And in terms of treatment, more use now of genomic panels to help with treatment, surgical techniques, radiation therapies have improved, chemotherapy protocols, and immunotherapy have all been used and all been improved over time, which could certainly also impact some of the mortality that we're seeing over time. Also, we talked about the demographic changes that could occur that could affect that denominator that we're talking about. So 1990 in Philadelphia, our population looked like this: 52% white, 39% Black. The Asian population was at 2.7% of our population, Hispanic 5.6%, and other 0.3%. Look at 2010, 20 years later, big changes. Now the largest group in 2010 is Black, 42%, 37% white, 6% Asian, so it's almost tripled there, 12% Hispanic, so huge increase there, more than doubled, and 2.3% in the multi-race or other. So huge demographic changes certainly can impact some of the rates that we see in disease, but also what we're using in terms of our denominators. So let's look at actual trends in age-adjusted incidence and mortality rates in Philadelphia. And this is some work we did a little while ago, looking at what was going on from 2005 to 2013, almost a 10-year span here. And for incidence, we divided all of these groups into their race ethnic groups. So we have green is Black, this blue line, all cases, everyone together. The red is white, and the red is white population, and purple is Hispanic. We didn't have enough numbers here to look at Asian as well. But what you can see over time is a nice decline occurring in each one of these groups. 31% decline for everyone together, 28% decline for white, 33% decline for Black, and a 38% decline for Hispanic. Interestingly, when we looked at mortality rates, and we were only able to calculate here for white, Black, and everyone together, because the numbers, again, very low for certain groups. But you can see for everyone, a 14% decline over time, 32% decline for white, but only a 5% decline in mortality for Black men. So you can see over time, there's actually been an increase in the disparity related to mortality, prostate cancer mortality in Philadelphia. So something we need to not only keep an eye on, but do something about. And the way that I computed these percent change. Now, when you look at trends, there are different programs you can use. You could do regression models. You could do something called join points, which I haven't used, but I've seen used. So join points is another program that can do this. But this is actually something you can do by hand as well. If you have a particular trend line that you're interested in, just doing some quick assessment of whether or not there have been changes, what you do is you take the latter two points, latter two incidence rates or mortality rates, you add them together and you subtract from them the first two rates or mortality incidence rates or mortality rates. You take the first two and you subtract it and then divide by the sum of the first two. Multiply by 100 and that gives you your percent change. If you see an increase over time, it will be a positive number. If you get a negative number, that means there's been a decrease from the original first two rates. Okay, so it's pretty straightforward. Okay, here we're looking at proportion of race and ethnic groups among all prostate cancer diagnoses per year in Philadelphia. So what we found here was that over time, there was a significant, this was done with regression models, there was a significant increase of Black patients, prostate cancer patients in Philadelphia, and a significant decrease of Hispanic prostate cancer patients, while white patients were pretty much consistent over time. But something interesting also was shown when we divided these into low or younger versus older men. And here I'm just showing the younger men where we found some significant differences with regard to high stage and high grade. So when we look at the high stage individuals, over time, they became more and more likely to be Black men. So this is only for those under the age of 65. So younger Black men are being diagnosed more and more with high stage disease compared to Hispanic and white men. When we look at high grade, more aggressive disease, the increase occurred here for Hispanic men. So younger Hispanic men, although less likely to be diagnosed in general, when they are diagnosed, tend to have a more aggressive disease compared to Black or white men. Again, something to keep an eye on and better understand, and then work to do something to decrease these disparities. Okay, and then one more thing I want to talk to you all about is some of the work that I've done in the neighborhood, which I find very intriguing when I think about prostate cancer disparities. So when it comes to neighborhoods and thinking about cancer, you can do this with any of the diseases that we're all interested in. But when we're thinking about cancer in particular, the geographical patterns that we see are very telling. They're very telling. Here we have Pennsylvania Cancer Registry data. This is an older data set that I used from 1995 to 2005 patients. And we're looking at Philadelphia and the four surrounding counties, Bucks, Montgomery, Delaware, and Chester. With these geographical patterns, we can see that the darker colors here indicate where the high stage prostate cancer cases are located in this 5-county region. So this is telling us who is most at risk for severe cases or high stage cases. It's telling us a little bit about why, we can begin to think about what is it about those counties? Are there particular risk factors that those populations have? There's something interesting going on there in particular. And then we can think about how, what's the best way for us to intervene to make a difference for the highest risk populations. And we can think about this. We can think about this across the cancer care continuum. So from prevention and detection to diagnosis, treatment, and survivorship. And some of my most recent work is really focused on prevention and detection. So we'll talk about that in a moment. But let's talk a little bit more about neighborhoods and cancer. So even just in Philadelphia, if you were to go around the city, you would find neighborhoods that look like these different neighborhoods that I'm presenting here. And you might expect that the health outcomes in these different neighborhoods are likely very different for a variety of reasons. So there are a number of factors that vary by neighborhood in the United States and that impact cancer. So the social networks that individuals have, depending on where they live, the support systems vary. The physical environment, the aesthetics, the noise and crime, proximity to resources, and access to fast food or healthy food differ as well. The institutions and resources differ. School quality, healthcare, policing, and jobs. The behaviors and culture and norms are all vary from place to place. The socioeconomic status, whether or not people are employed or have good education, high incomes, varies from neighborhood to neighborhood. And of course, especially in Philadelphia, the race and ethnicity varies from place to place. And then that, of course, would be associated to whether or not there are certain genetic polymorphisms that are more prevalent there, shared customs and geographic history that might all influence risk for a particular disease or poor outcome. So why are neighborhood characteristics important in the study of health disparities? Well, we know that neighborhood characteristics are associated with risk of disease, poor health outcomes, and mortality. In fact, the degree of deterioration and urbanization, the percent of low-income residents have all been associated with poor health outcomes. And neighborhood factors, of course, vary by race and may be related to cancer outcomes. And some of the underlying factors that connect neighborhoods to health could be stress and just accumulation of risk factors and multi-level risk factors as well. So patient level, but also social level, neighborhood level exposures, environmental exposures, and policies that influence neighborhoods differently. And also African Americans, we know, are one of the groups more likely to live in disadvantaged areas. So we really need to pay attention to this when we're thinking about the disparities that we see with prostate cancer in African American men. So what really got me thinking about this was some early work that I did with a study called SCORE, the study of clinical outcomes, risk, and ethnicity, which were participants, patients from the University of Pennsylvania healthcare system. And it was very interesting to me. We went to one particular clinic. We ended up going to several later, but we went to one particular clinic and we found that this was a diverse patient population, everyone going to the same clinic, seeing the same doctors, potentially getting the same treatment, being diagnosed with early stage disease at the same rates. But it was very interesting because the white patients lived in very different places compared to the majority of the Black patients. So for the Black patients, they were much less likely, significantly less likely to live in high income areas. They were much more likely to live in high poverty areas and much less likely to live in places with higher than high school educational attainment. So the neighborhood demographics where these individuals lived were very, very different. We did some additional work with this particular study and also added in some Pennsylvania Cancer Registry data. And this is showing Pennsylvania Cancer Registry data from 1995 to 2005 for our area. And what we found was that in areas that were more socioeconomically deprived, there was a tendency for higher tumor grade at diagnosis. So a higher tumor grade showing more aggressive prostate cancer. And that was true for white and for Black men, but you can see from this even more so for Black men. So with studies like that actually led me to want to do this particular study I was able to complete with some of my colleagues here at Jefferson, the IMPACT study, empowering men about prostate cancer together. This is an intervention study that we hope can be used to help reduce some of the prostate cancer disparities we see in a very targeted fashion. So the IMPACT study's goal was to develop a targeted educational intervention to increase knowledge about prostate cancer screening in high-risk neighborhoods. And it had some novel components. We focused on neighborhood risk, which was determined by using state cancer registry data. We used a mixed methods approach. So we used both qualitative and quantitative data to help us to develop the intervention. And we had an amazing transdisciplinary team working on this. The study aims were to identify high-risk neighborhoods, then to develop a targeted prostate cancer screening intervention specifically for those neighborhoods. And then in aim 3, test the prostate cancer intervention against a healthy lifestyle control group. And our outcomes were prostate cancer knowledge, prostate cancer worry, and patients having or participants having the intent to follow up with prostate cancer screening. A sub-aim was also to observe the rates of prostate cancer screening, but the study really was only 3 years and didn't go long enough for us to do the sub-aim. Okay, so on our first aim, we identified high-risk census tracts for prostate cancer, again, using the Pennsylvania Cancer Registry data. We were able to determine where the most cases were occurring, the most incident cases, where the most prostate cancer specific mortality was occurring. And then to do something called mean aggressiveness, where we took a combination of stage and grade together, tumor stage and grade, to really understand the aggressiveness of the disease. So we put all of those together and created a composite score, which gave us very clear indication about where the most severe prostate cancer cases and burden was occurring in the city. And you can see where they occurred, where these red and orange spaces are around the city. We identified specific neighborhoods from that. Here we have Northwest, North Philadelphia, not all of North, just certain neighborhoods here. Same with West Philadelphia, and then Southwest around University of Pennsylvania area. After we identified the areas, we conducted focus groups in those particular areas. The focus group themes that really came out, including ways to reach men in the community. The men suggested that community recruitment should come from within the community. So not that we come out as Jefferson investigators and come and do recruitment, but that we deputize individuals to go into the community on our behalf and do the recruitment. Also, that we advertise the program as more of a health program rather than a cancer program, because cancer tends to be scary for some of the men in the neighborhoods. Awareness and views. We realized from the focus groups that there was very little knowledge about prostate cancer, and confusion with colorectal cancer screening as well. And a little bit of what I don't know won't hurt me that little bit of that was going on as well. And we needed to be able to develop something, a program that might get beyond that particular attitude. Also, the look of the intervention, they really wanted the sessions that we would have for them for the intervention to be held at community sites with a small group of men, to be interactive and with no judgment about their lifestyle or their behaviors or their perceptions. Also, the content needed to be plain and simple language about cancer and screening, and the post-session engagement required a booklet of information that the men could take home to have for themselves, to share with others. They wanted to also know how to talk to their doctor about screening, because as I mentioned, some of the doctors weren't doing it anymore, and the men would really have to be proactive in this. And also, they let us know it's okay to do some follow-up calls by phone, which was necessary for this particular type of study. So for the intervention development, we recruited and successfully trained a team of peer health educators who came from those neighborhoods that we identified. We designed a community engaged educational intervention to educate men about prostate cancer and screening, and designed a control intervention about healthy living. Also, we located neighborhood host sites and enrolled 273 men into the study, conducted a small group educational session where we, again, looked at endpoints related to knowledge, worry, and intent to screen. And we had pre-session and post-session tests as well. So here's our team of peer health educators, at least some of them. These were African-American men all over the age of 40 with long-standing ties to the neighborhood. Some have a healthcare organizing background, others did not. They were just lay people, and all were passionate about improving the lives of men in Philadelphia. The intervention pamphlet rather, here's the front cover on the left here, where we are certainly targeting the groups of men that primarily live in these areas. Take control, know your options. Here's one of the pages where we talk about understanding your risk, the age, race, ethnicity, family history as the primary risk factors, and gave men opportunity to really talk about how these things are impacting their health and their health decisions and interactions during the sessions. The demographics of our final sample was 200, we had 273 men, the majority, 92% were Black, median age of 53, age range 27 to 83, 88% had health insurance, and 62% had less than a college education. So here are some of our findings. Here we had 2 neighborhoods or 2 areas of the city that were control groups. The other 2 were our intervention group. And what we found is that in terms of knowledge of prostate cancer, at baseline, they were very similar. No differences really here. However, as we move along, in fact, we'll just focus on what happened by 4 months post-session, post-intervention. It was very interesting because there was a slight increase actually for both groups. So that was a little bit unexpected. We also focused here on concern, whether or not individuals were concerned about prostate cancer. And there was moderate concern in both groups from the very beginning at baseline. And by the time we ended, we didn't do anything about decreasing the concern. It stayed about the same, which actually kind of makes sense when you think about it, that it might be the same as people even become educated about it and realize their risk. And then in terms of deciding to be screened, there was an increase over time for both groups, which was surprising. The increase from not really being sure if they wanted to be screened, somewhat likely, to everyone almost wanting to be screened by the end. was very impressive and perhaps indicated that the men, regardless of the session that they were part of, sorry, just plugging in my computer, regardless of which section they were part of, actually were convinced, perhaps in the session by other men, even if they didn't focus on prostate cancer, just to be more engaged with their own health. So we found that to be very exciting, very positive, although unexpected finding. So the next steps for us, we're already involved with our continuation of this with our colleagues at the University of Pennsylvania. They are continuing the impact study, focusing on the areas that we once used as our control neighborhoods. Those are now our intervention neighborhoods. So those men in those neighborhoods are getting the prostate specific education. And the study is ongoing. So very excited that we're able to work with our colleagues there to continue this work. We think this also could be a model for other cancers and other diseases. Some of the other areas I work in right now include breast cancer, lung cancer, colorectal cancer, head and neck cancer. So very excited about thinking about how we can incorporate some of the same types of techniques for other diseases. And then at the state level, we're very interested. I work with the Pennsylvania Cancer Coalition. We're very interested in not only continuing the surveillance to understand what's happening with these rates and the disparities over time, but we are working on brief reports now that will help us to document the disparities as we see them, and also to share that information with legislators, with community workers, with various individuals who are doing programming and thinking about the resources that are necessary to improve the health of various communities. So it's all very exciting and ongoing. So thank you for your attention. And I hope that this was very interesting to you. Have a good day.